everybody. If you could make your way back to your chairs, we're going to move into the next session, which is a panel session, and I'm delighted to welcome you all here. Again, pay my respects to the custodians of the lands on which we're meeting, Wurundjeri people of the Kulin Nation, and pay my respects to elders past and present, and to the many Aboriginal and Torres Strait Islander people here in the room with us, which is, to me, the most positive aspect of APPRISE moving forward. But we're talking about what the future is for research preparedness and APPRISE, and I have the clicker of power, so I can actually move the slides myself. And Sharon gave us a great timeline at the beginning, just talking about, the various stages of APPRISE, but I'm just going to step into that timeline at a few points, just to unpack in a little more detail some of the content of what happened at those times. So back in, actually pre-2015, when H7N9 emerged, there were a number of calls convened, and Jenny Furman and Anne Kelso and others at the time were keen to set up a business case for a research preparedness consortium in line with what was happening around the world. And so at that time, I was commissioned to undertake a consultation process and wrote to many people. And I remember Pete Massey introducing me to the idea of streams and currents rather than pillars and cross-cutting disciplines. So it was all much more fluid and flexible and lovely, which I retain that emphasis. But back in 2015, then the synthesis of that was NHMRC did put up a call for a special CRE, and just the wording of that, there was a need for research ongoing before, during, and after as part of an emergency, including pandemic response, noted by the Australian Health Protection Principal Committee, and that was identified as an enabler of the Australian communicable disease control system. Pointing to the fact that other countries such as UK, Canada, and the US have these structures in place that are integral to emergency management, and those were largely provided through intramural research institutes and well-funded networks. So, this CRE, which as Sharon pointed out was $5 million, twice the usual CRE, could provide the foundations for an ongoing coordinated national effort against emerging infectious diseases. So this was NHMRC providing funding for something that could become a structural entity as in these other countries. And so we had that initial consultation, which Sharon mentioned, and the feedback there, really, there were several recommendations, and I'm not going to read them all, but I'm sure these slides can be shared later on. But broadly, there was the research priorities were endorsed by HPPC, but more clarity was needed on broad stakeholder engagement, key messages and communication, alignment with CDNA priorities, and translation pathways. And so as the work plans evolved and as the network evolved, we really tried to address these issues. And in 2019, Ross Andrews and Emma Field led a theory of change for the network, reflecting on where we'd been and where we were going, and reinforcing this vision of APPRISE that our research informs and enables preparedness and response to infectious disease threats and emergencies in a timely manner to protect and promote human health. So 2019, were we completely ready? Not so sure. And the goal at that point, generating new knowledge that informs infectious disease response nationally and globally with these 4 Ps, platforms, partnerships, people, and permanence being our sustainability. I do love my alliteration, and if any of you've read the Health Emergency Preparedness and Response Framework, it has 5 Cs. So let's keep with the theme. But the key challenges and gaps that were identified: systems, strategy, and implementation. So under systems, we all recognised, and there was a lot of discussion in the room in Brisbane in 2019 about barriers to data sharing and integration and challenges for multi-jurisdictional projects. Complex governance issues by state, impeding research. Weak national clinical trial structure was noted with the exception of the ICU network. So there was fragmented recruitment and few outcomes, and this happened through COVID. There was no strategic public health research framework during COVID, which meant there was difficulty addressing real-time gaps. And so I think Sharon referred to a call that I led in January 2020. I was like, well, what do we need to know? Everybody was working out what we needed to know. And in fact, that's an iterative process because the knowledge needs continue to adapt over time. So how do we make that flexible? In implementation, there were difficulties with real-time engagement between research and public health. I won't go into the boring divide between research and public health, which I think should be a continuous progress in the quality improvement cycle, and limited mechanisms for public health evaluation. So many of the measures that were deployed, there really wasn't structured data collection in place to enable evaluation of their effectiveness. So in this next phase consultation, and Sharon referred to the next consultation document that went up, there's new platforms which regrettably do not all start with the same letter. So that is a downer of the new vision, but I'll wear it. But basically saying that the key platforms were public health responses, clinical investigation, biobanking, social science, modelling, and evidence communication and evaluation. And I think this communication part and sustainable public trust and all of that has become much more predominant as a key enabler of implementation through our lived experience of the past few years. And these platforms were there to address preparedness requirements, agreed objectives tested through core inter-pandemic activities. And obviously a pandemic preparedness network is not just preparing for pandemics, it's actually doing things that are useful in that inter-pandemic period to be useful. And working to integrate relationships between academia, public health, clinicians and community. So that's kind of where we came from and how the iterations went out and how the content of what we talked about trying to do has changed. Obviously in the current iteration with the funding through the CMOs group, we have, the current projects that you're hearing about today and the programs of work and the ongoing investment in the first network capability. But through all of that and all the talking and all the doing, I've got a fantastic panel here today, and I'm sure you're familiar with all of them, but obviously we have Paul Kelly, Tania Sorrell, we have Julie Leask, Kristy Crooks and Allen Cheng. So between the six of us, we have the usual APPRISE problem with gender parity, but, we've done our best. But there are 4 questions I'm going to ask this panel to reflect on. And while each of them is sort of going to be primarily pitched at one panel member, everybody's welcome to have a go. I'm interested in everybody's thoughts because all of these people were involved in different elements of national, jurisdictional, evidence generation, response, policy, all sorts of parts of that whole cycle. And then we'll put this out to the floor because I'm sure everybody here would love to pick their brains as well. So we'll do that. And we have until 2:30 with them. So it's a good grueling that they're all going to have, but we'll do it very gently and kindly. But the first question that I'm going to put to the panel is what has APPRISE and the research community, and so this is something where I'm obviously going to start with the researchers and I'm going to lead this one off to Tania. What have we learned about research preparedness from the COVID pandemic? And so if Tania makes a start, then we'll see what the other panelists have to say. Thank you.
Okay, well, what we learned was that every pandemic is different is the first thing, because this all started off, as you heard this morning, with the influenza pandemic, and the Commonwealth did think it had some really well-prepared plans, none of which seemed to be absolutely appropriate when COVID came along. We did recognise, though, that every pandemic needs coordinated but global collaboration, and I think some of that's come out this morning. What I'd like to do is just reflect on the Beat COVID, which Sharon referred to this morning, the Snow Foundation entity that actually picked up urgent research that was needed on top of the, grant applications that were called for prior to that, which sustained new vaccine development and a lot of really long-term basic biological research to underpin how we might deal with the pandemic. And as has been said on some of the occasions this morning, there were some fairly non-controversial process issues that were identified as problematic, like if we're having a lot of competitive grants, you've got to write the grant, that's got to be assessed, the money's got to be got out the door, and there were significant delays in doing that as a competitive process. Ethics approvals without pre-approvals, a major problem, and governance processes like MOUs between institutions, which can take up to 12 months, as Miranda well knows, to generate. Those should be relatively non-controversial and easily fixed. There is an issue of highly competitive grant calls versus limited grant calls, and I suppose the most glaring example of the competitive grants that the then government was keen to prosecute was in the clinical trials area around COVID, where there were multiple small clinical trials, none of which came to fruition because we didn't have enough patients, whereas a different scenario in the UK enabled national trials to be done. And I think it's something we should reflect on for the future. But there were a number of enablers that we were actually able to take advantage of, which I think facilitated Australia's research response. And they really include the things we have talked about a little bit, the pre-established and funding research partnerships, and networks. There were a range of CREs funded at about the same time that actually had generated data together with other national or NHMRC and other grants that really enable us to get started fairly quickly. And I must admit, I thought a really good idea, despite the fact we didn't like it, Sharon, of the APPRISE initiative was the co-design process, the initial process that really refined what the researchers thought was important to have feedback from what the public health and policymakers thought was important, the community thought was important, and as has expanded in COVID, the Torres Strait Islander Aboriginal, the First Nations people think are important. So I thought that was a great positive. I think the other value of this particular CRA was the capacity with CREED, which was looking really at the genomics in public health kind of capability, was the ability to evolve research questions and fund some, if you like, adapted or adaptive studies over the course of the grant. And fortunately, as you know, in CREs, you tend to underspend. So we were able, with CREED underspending and APPRISE contingency funds, to really kickstart things during COVID. What are the issues that might be a bit more controversial? They're to do with funding. No.
He's got deep pockets. Keep talking. Yeah.
I think one of the things that became really evident was that this is a global undertaking, but it needs to have developed a coordinated national strategy for this kind of research to be undertaken, and the capability to ramp up quickly, because in an inter-pandemic period, obviously, there's a lot less going on than there is during a pandemic period. But that's not to say that we shouldn't be developing further and integrating cutting technology. And that really links into the platforms that we were talking about that we need to have sustained for new diagnostics or drug development, or other things that I don't really need to articulate in the interest of time. We need to think about building workforce capacity or maintaining it, and think about surge capacity. We need to think about maintaining and evolving expertise in all of the things that go into the process of dealing with a pandemic. And that I'd like particularly to mention social and behavioural and ethics-based research linked with public health needs and surveillance. We need a process by which is an authoritative group of people that is actually keeping track of this, and maybe that could link into a CDC in some manner. I would particularly like to amplify what, where is she? Jane said this morning, which is to do with the relevance of ethics-based research to develop guiding principles, engaging professional and public values into key questions, because we do really have to have the endorsement of relevant communities if we're going to implement some of the things we've developed and actually have them taken up by the community. So I'll stop there, really reflecting that there seem to be a couple of major things. One is how we develop and maintain coordinated national evolving strategies for these kind of problems. Some of the things can be linked into other public health initiatives and should be, I think, non-negotiable or not controversial. And finally, how do we make sure that the sort of entity that APPRISE is can be sustained, but can also evolve and bring in appropriate people as they come online? Thank you.
Thanks very much, Tania. That's great. You really picked up a lot of key issues there, and some of them, like structural networks and workforce, will come up into later. But very keen for other members of the panel to reflect on any of the above, and also any other themes that particularly you think are important in that research coordination. Yeah, Allen.
Is that better? Yep. I mean, I think if you sort of reflect on, the things that did work, having now worked in government a little bit, like governance is really important. So, the fact that we had AHPPC, CDNA, TAGI, all those committees, and they could step up to, it was a system that was already working. But in research, there's not really that sort of analogous system. So when all those questions come across from public health to say, well, what should we do? What is the evidence underlying this? there isn't that system on the other side and that's where I think it would be a key role for APPRISE. I think probably the other points are probably quite similar to Tania's points, and she's probably put it a lot better, but I felt really that the usual research mechanisms just didn't work in pandemic time, and part of that was about trying to anticipate questions rather than, when you write you write a grant around the question that you have at the time, but by the time you get the money a year later, that question is no longer relevant. And I thought the UK did that quite well, but what that really meant was that they very much had a very top-down approach to say, well, these are the questions that we're going to anticipate. We're going to have, do vaccines work in a population? What about mixed schedules with different vaccines? Recovery and panoramic as the sort of major clinical trials. And they went out and commissioned that work rather than saying, getting researchers to put in, submit research grants to try and come up with that. And then, they were able to get a lot of those things off the ground. The other thing was that, and I think, Paul made the point that, the CDC isn't going to be a research funder, which I can understand why, but research is on very much a spectrum from very basic research, which is going to be clearly out of scope, to monitoring and evaluation and very operational questions, which clearly is probably going to have to be in scope. So where that line is going to be drawn between, what the CDC is going to fund and what is going to be left to funding agencies, and then in a pandemic or, an emergency situation, how might that be different? And, it comes up all the time. So as an example, since the pandemic, Japanese encephalitis vaccine, can we give it intradermally? That research grant is still working its way through, through processes. And by the time, there won't be any Japanese encephalitis by the time that question is answered. So, we need a mechanism to fund that sort of research, I think.
I mean, just reflecting too, though, Ellen, even if that research grant had been funded, there was also often the issue that the research just couldn't be done in time for the question because decision-making has to be so fast. So I think that also is the preparedness element, isn't it?
I remember, I think it was at one of the APPRISE sessions very early, and Jenny Furman was on, and she said something that now I understand very well. She said the best research is the one where the result arrives just before you're about to make the decision to inform what you're going to say. The second best research is the one that supports the decision you just made.
Yep. And that's the reality, right? In an emergency situation, they have to be made fast. Just any other reflections on research preparedness from, yes, Julie?
Yeah, so I want to sort of take the example of trust. And for those of you who don't know, I'm a social scientist, so I use qualitative and quantitative methods, and our team does as well. We're called the Social and Behavioural Insights in Immunisation Research Group. And we've been doing research on immunisation uptake in particular for many years. And trust, it turns out, we've all acknowledged was so fundamental to so many aspects of managing COVID. It was found to be the biggest predictor of country success, according to one analysis published in The Lancet. And that was interpersonal trust and trust in government. And it's fundamental to how people listen and act, how communities are motivated to engage. And, you mentioned earlier, Paul, about the JE issues with, engaging with piggeries and the trust issues there. That's another, I guess, case in point that there needs to be trust between government and industry and trust in many different networks for us to successfully manage a pandemic. And this kind of research is best done before the pandemic, like all good pandemic planning. But so I can tell you that social research can teach us about the different impacts of the way we communicate uncertainty. And one of those impacts is on trust. So if you're overconfident or you don't share uncertainty, people can lose trust. But if you communicate uncertainty, people can lose the clarity of the message. So there's some really difficult balances there. But we know that because trust is so important, if you're going to prioritize your actions according to what is important, then go for the difficult of two options of maintaining trust. So do communicate uncertainty. That comes from social research. Trust can be dimensionalized. So it's such a waffly term, but it can actually be broken down into different things like confidence in institutions, in science, in each other. And there's many different ways of measuring trust. Social science does that, particularly psychometrics, which is a part of psychology, which looks at measurement. So we've got to be able to measure these things well. Bringing insights from First Nations communities, a lot of that will be about trust. And looking at how we best communicate is often centred on what we understand to be what sustains trust. You mentioned earlier, Allen, how do policy makers use qualitative research, if at all? I can tell you that when we had conversations about the AstraZeneca vaccine issue and the safety and all the difficult balances that ATAGI were doing at the time when thinking about this signal, that when we talked, qualitative findings were definitely informing what I said to you. So whether you know it or not, qualitative research is influencing policy in different ways, but we need to find better ways of using social scientists who specialise in these areas rather than just going for the big consultancy firms who are brought in because they're quicker and can be more easily managed by government. Over.
Thank you, Julie. And Kristy, yeah.
Just reflecting on the APPRISE journey as well. We set up those, I was going to say pillars, but, with the key populations. And there was a glaring, obvious gap with First Nations researcher. I think there was only 3 of us at the time, and I was very, very, new to this space. So over time, we need to build the First Nations workforce, and so we don't burn out existing First Nations researchers or public health experts or practitioners. Ethics has been a real tough process as a First Nations woman doing research in First Nations communities. I've always found it really hard to get ethics approval without having to prove myself as someone going in and doing the right thing. So I kind of want to have conversations with people today who have got ethics approval and see if you've had a hard time like I have. The Ramsay funding that we got proved to be, like I said, a robust way of governing grant funding. We did it in a really good way that we had governance principles and values embedded in that was informed by First Nations people. And so I think, we need those kind of processes embedded into grant funding, where we prioritise First Nations-led research that's governed by First Nations peoples, because that builds trust with community and to be able to do work. And, we can identify research areas that are on the base of needs and priorities of communities and not dictated by government. And another good thing about APPRISE that I found is that we had all this planning in place before the pandemic, and we were able to kind of adapt the frameworks. And a big thing for me was being able to work and be introduced to people that I would not have been associated with previously. So, that collaboration is really important. That relationship is really important. And, really privileged in order to be working in the first space and bringing other people along on the journey as well.
Thanks, Kristy. And Paul, I think you get let off this question because you're going to lead the next one. But I guess from the other side of the fence, and Allen's had this experience as well, but, what was the perspective of government decision makers on the role of APPRISE in addressing emergency response needs? So was the model relevant? Was it accessible? Was it visible? Was it useful? Or is something a bit different needed in the future? Because obviously a lot of different systems and processes and information needs were met in different ways, like either within the department or through NHMRC committees or other things. How accessible and useful do you feel it really was? And, be honest.
Be honest with the constraints. Yeah, I will actually start with a little comment on the first.
Yeah, sorry.
The first one.
Okay.
No, but that's fine because it's related, right?
Yeah.
So I think it was the first or second week of February of 2020. I called a research symposium. Was anyone there in Canberra? You were, yeah. I think it was. and Sharon was,
Mm.
and Cantor was online from WHO in Geneva, where the same thing was coming, and we came up with the same answers, which was good to know. That was my first learning of what the term policy authority is in government. Insofar as I had no policy authority to have that, it was just a good idea at the time, and I thought it was a good idea, and we had some great thoughts. But then I was hit by the famous Hunt storm that happens occasionally. It's the only time he ever shouted at me. Morrison shouted at me a few times more than that, but yeah, telling all.
Badge of honour.
Yeah. It's in the book. Has anyone read Life as We Knew It, by Aisha Dow and Melissa Cunningham? It's there's a few of my anecdotes in there, including a shouting match. But that was a pity, because what he interpreted it as I was putting government on the hook for funding all of those ideas, and that wasn't the idea. The idea was to get researchers together and get a sense of what, from research perspective and policy perspective, together, coming up with what needed to be done. Now, I think many people have said whatever we can do beforehand, we should do. But I think that comes to platforms, to trust, to networks, all of those things that APPRISE was set up to do. And I'll come back to a specific protocol in a minute, but having the systems set up so that you can respond to the thing that's in front of you at the time, because it's not going to be the same next time. We all know that. It'll be a different organism, potentially affecting different people, perhaps with a different transmission dynamic, pathogenicity, etc. So we need to have those bedrock. And I think the JV example I gave was a classic of that. We didn't have any of that, as distinct from what Allen was saying with the setup that we had, at least in that structure. So I think APPRISE was certainly part of that structure coming in. Big disappointment. I remember those discussions early on when we were meeting in 2016, 2017. We would have a protocol ready for disease X, all the ethics done, all of the places ready right across Australia to answer the questions. We didn't. So I think that was a real disappointment as a policymaker, that we had this expectation that would happen, and then Sharon, came around and talked to the Chief Health Officers at APPC recently as we were working towards this next iteration of APPRISE. And I think you were surprised, weren't you, about the fact that you weren't greeted with open arms. And I was too, a bit, because I thought they were a bit harsh, Sharon. And I think we talked about it afterwards, gave you a debrief. But I think that was that was front of mind, that there was an expectation which wasn't quite fulfilled from that perspective. There were many other parts that were fulfilled, and I mentioned already this morning the role that Jodie and James and the whole network of the modelling team were able, absolutely fundamental to the way it worked. And that's again, many of my colleagues at APPC wouldn't realise that was based on years of research and years of trust building, and the back, underpinning all of that modelling was very solid stuff. Much of it some of it from APPRISE, others from other sources. But that was a key component. So I'm getting to the second one now. So I think if I was thinking forward to the next pandemic, which will hopefully happen after I retire, will be building on some of those elements that were just talked about this morning. But also thinking about the pre-preparation of actual things that could be done quickly. Certainly within the planning for the CDC, and again, I just really reiterate, these will be decisions of government. I can't say how they're going to end up, but the idea of having a role in preparedness, including research, and a role in guiding the distribution of research funding in a pandemic and in emergencies is definitely part of that process we're working through. How that will actually play out will just remain to be seen. I'm almost certain, as I said earlier, that the inquiry will be very strong on evaluation of public health interventions. That's Catherine Bennett's main thing she talks about. So I'd be very surprised if that wasn't in there, and I'd be very surprised if that wasn't taken on as part of the government response to the inquiry. So there'll be that element as well. So real-time research. How that plays into how funds are distributed is very difficult. Under the public service sort of legislative mechanisms, there's a whole chapter on competitive funding, transparency of funding, and etc. And we are hampered. Government is hampered by those things. But there's there's good reasons why they're there, of course, about corruption and so on. But it's how you balance that is really difficult. And we've all experienced, what happened with some. There's been a lot of money spent in research through MRFF and NHMRC through the pandemic. But there's been a few classic examples, but one of them was actually the AstraZeneca, the TTS. Can't remember what it stands for, Alan, but yeah, that one. Thank you. The funding came through, a year after that it kind of disappeared, and we weren't using AstraZeneca anymore. So we've got to be better with that. Nice paper published, and AstraZeneca is still being used elsewhere, and so but that wasn't in real time. So I think that's probably enough from me.
I'm going to give you an extra one in that, like in terms of actually having those ready to go things. What about scenario exercises? What about inter-pandemic exercises? I know for years, Jenny and Rhonda were keen to get us doing, first few X protocols in seasonal flu. I guess, what do you think the role of doing in peacetime is to actually make sure we're ready?
Yeah, I think absolutely. And I will say, whatever the CDC ends up looking like from the 1st of January as an interim period, there will be an exercise next year and in the first quarter of next year, and we will. I'm committed to that. And I think having the research element of it embedded would be a really good idea.
Yeah. I'm just going to pitch that one. Thank you, Paul, to Alan as well as the other one who was on that side of the fence.
Yeah. So if I was sort of replaying it again, now knowing what I do, what could have a prize been like? How would we have wanted to organise the research community? So clearly MRFF and NHMRC have the purse strings, but how would we have formed a research committee, encompassing everyone who does research, to try and anticipate what are the big questions that we're going to have to answer? Then we can say to NHMRC, well, these are the things that we anticipate are going to be questions. These are the things that other countries are doing, and we want to play with them because may not have all the cases, and other countries may do that. And then which bit are we going to fund, and how are we going to prioritise that? So as a big group, so we had the AMPI, the Health Management Plan for Pandemic Influenza before. What was the research side of that? What did the plan for research look like? And could we have that sort of pre-prepared? Then for the things that are going to be really early questions, how do you treat a new disease? What's the epidemiology? What are the transmission characteristics? What are the things that would have to be set up early? Then for the things that are going to be sort of latter questions, like, safety of a vaccine, which, we don't even know what the vaccine is going to be. We've got to probably a bit more time a lead time to do that, but the other things have to be prepared. So the one study that probably was very successful was REMAP-CAP, investigating that, but tocilizumab and steroids as treatment for severe COVID, that came straight out of that. And that was because that was a pre-existing trial that was running already. We hardly contributed any cases here because we didn't have any cases, but it was running in other countries as well. And the work that we all did together to develop a protocol meant that, that got off the ground very quickly and could answer those questions very quickly. So I think it is, in preparedness, it's partly about governance and, how do we want it to look? And, in making all of those plans, part of it will be an accountability mechanism and, making sure there isn't corruption and just money getting shoveled out to people's friends. But all of that just sort of needs to be thought together and probably in consultation with the funders, I think.
Okay, thank you. Some good thoughts there. So I'm going to move on to the next question, which is how can networks like APPRISE help to broker between researchers, public health decision makers and the emerging CDC? I would also say the community to support effective communication, collaboration and priority setting. And I might actually put this to Julie and Kristy in the first instance to reflect on whether networks like APPRISE are the right networks, or whether we need networks of networks, or, you know, what actually are the enablers to making sure that voices are heard effectively across different settings and that all of the priorities are in the room.
I haven't really thought about this one, but no, it's okay. I think my experience with APPRISE has been a really good one. But like I said, there's only been a couple of us on the APPRISE. And so it's stretched, you know, our work and our load and our burden in everything we do. So I don't know if networks of networks will work, but we've got to build the First Nations workforce in public health, and whether that's looking at the public health units or institutions and seeing how culturally safe they are, and understanding why there you know, aren't many people working in this space. I know we've got lots of epidemiologists who've graduated from the MAE, but there seems to be not many people working in infectious disease at all. And that's where we need all our expertise working with us. So, and also thinking about the CDC, I'm probably just going off the track, but we need to have a First Nations unit that's resourced and funded and staffed. But also when we're talking about First Nations people, it's nothing without us. So, you know, I wouldn't want to see all just First Nations research or priorities or issues just going to the First Nations peoples, but having First Nations peoples embedded across all the different systems, because whatever impacts on non-Aboriginal people also impacts on First Nations people.
So I think that, so I wasn't really I wasn't in the core APPRISE group. So I'm a good person to ask that because I'm not in the club, right? I did benefit from some funding from CREED, which is connected in with APPRISE. A little bit of funding to look at communication needs early in the pandemic, which took a long time to get ethics approval, but anyway. And what I think is very important is that we have in networks like APPRISE, which have done a lot of good work in building capacity, which we'll talk about next, in having people and relationships there to utilize in an emergency when you know, sometimes that relationship is the way you can access that information or that evidence. So that's essential, and that's what networks like that do. But how they can do it best is to make sure that it's genuinely collaborative and that doesn't have a sense of cliques or fiefdoms. Now, I think APPRISE has tried to be genuinely collaborative and open in its structure from my slightly outsider perspective. And I think there's been a purposefulness in that. But let's name the elephant in the room, which is that in research, we exist, and I keep talking about this, between collaboration and competition. And the systems in our institutions and our funding often set us up to compete with each other, whether it's between institutions, research groups, or whole cities and states. So I think that, you know, we exist in that reality. Let's do everything we can to keep our eyes on what our goal is, which is about human health, well-being, preparedness, the stuff that really motivates us, and not be too distracted by the politics and competition that can come with those pressures, and do things that make sure that we acknowledge that and give people a sense of fairness and participation. So making it an open network in whatever way you can, making funding opportunities as transparent as possible, and fair, acknowledging that sometimes those relationships can help those opportunities, and that can be important when things are rushed. So I think it's so important that we focus on what we can do to collaborate and have transparency of process and fairness of process, and make sure it's genuinely collaborative, acknowledging that we do as researchers in particular exist in institutions and structures that also encourage competition.
I guess, Tania, would you like to reflect on that at all in you know, in that challenge of being researchers and the way we all have to survive? Well, no, it's just you can or you cannot. It's hard. Yeah. Yeah.
I'm sorry. Briefly, I guess we've just got to look at the way research is funded in this country and maybe do some iterative work with the NHMRC MRFF review that's going on to think about the role of investigator-driven research in smaller programs, if you like, versus these large multidisciplinary, necessarily multi-centre initiatives, which can perhaps maybe be funded through the MRFF or some process where there are significant funds, but actually require engagement of different research groups. I think, and Sharon, you might know more about this than I do, the NIH operates in this way with certain key questions. I imagine they have in the UK as well. So that would be one reflection, perhaps.
And I'm going to come back to you, Paul, but I want to frame the question particularly. I mean, you raised this problem of policy authority for you to talk to researchers, right? And if you're, the primary end user of preparedness research, what is the participatory process by which you're enabled to engage with this community and with the funders? And the consultation sort of recommended both of those things happening for the CDC, but I know you can't tell us anything, but, has to be movement, Paul. Yeah. Personal opinion, not that of government.
Not to be minuted. So my reflection on the MRFF, I think, and that consultation that happened, was it last year? I can't remember now. Earlier this year, was really interesting because I think the MRFF was set up for a particular purpose in response to a perceived community concern with the way that NHMRC funds were distributed, and that community, I would say, broad community, but also research community, definitely the political class and policymakers. That there was a clique, to use your term, that was getting most of the money, and others were missing out, and that the investigator-led research was not fulfilling the needs of policymakers to a certain extent. So that was the basis of it. Somewhere along the line, it became extremely politicized, and that's a bit not to minute, because that. But I saw that in real time. It was idea brain farts, if you like, from various politicians, and some of them very, very worthy and led from their understanding of what the community was looking for. But somewhere along the track, I think we lost exactly what we're talking about here is what are the big questions that need to be answered in ways that will never happen with relatively small investigator-led ideas, even if they're fantastically good ideas. And this is one of them, what we're talking about here. How do we prepare for the next pandemic so that we have a research-ready ability to answer those specific, clear questions to guide the response? How do we have a ready workforce to do those evaluations of those major social disruptive things that we do in public health? We didn't have that, and the MRFF should be that mechanism, but it isn't. There was one that I've talked about, the TTS one. There was one before that during the bushfires in 2019-20. I somewhat against policy authority because it was before this thing happening. I talked to a range of colleagues and friends that I know around Australia who are interested in various aspects of the effect of smoke and particulate matters on respiratory health and other mechanisms. And I very strongly suggested that they all talk to each other and come up with a single grant proposal. I wasn't part of the assessment, but all of that money was given to a single person who wanted to do a randomized controlled trial about mask use. Whereas the one that would have come from this other group would have been far more holistic and systems oriented. So we need to think about how those MRFF mechanisms might work in whatever new structure I'm not allowed to talk about might come in the next few months, because that's the opportunity. And so when you're asked, please put your hand up and make a suggestion about this, about preparedness and research.
Thank you. Alan, did you have anything to add on this one?
Not sure that I do really. I mean, I think just going back to, what is shovel-ready research in the context of, we are now, having done this once, we know what the questions will be for the next one. We probably didn't have quite the same feel, but we did have 2009 to. So in 2009, I was asked to be on the HRC, the New Zealand Medical Research Council, Health Medical Research Council grant scheme for their H1N1 grants, and they don't have much money, and they have a smaller pool of researchers, but a few people that work in the same area, and they did say, look, we've had 3 grants from along the same themes. Can you go back, get together, come up with one, and then resubmit that to us, and we'll try and fund that. So I think there is a way of still trying to harness investigator-led research while still trying to sort of keep an eye on what are the big questions that need to be answered, and try to anticipate what will be next.
I would also call out, this occurs to me that one of the other challenges we had was the jurisdictions having their own competitive funding research projects, as well as the Commonwealth ones. And, if we look at the current revisions, this new pandemic instrument, being negotiated by the International Negotiating Board, it talks about research equity and access. And, not only did rich countries hold on to vaccines and resources, they held on to research funding. They, had competitive and uncoordinated research funding, which reduced its effectiveness. So, within Australia, how do we deal with not just what individual researchers want to do, but what state governments want to fund, and then what the federal government wants to fund, and what is our vision for, throwing that more broadly into the context of the region and ensuring research equity to other communities and populations, because around the country, different states and territories had different amounts of money to throw at research too. So, is there any within this? I know the CDC doesn't do research, but what is, I guess, what are people's personal views or your personal views on whether we should be trying to think about that kind of imbalance? Sorry, that's a nasty one, isn't it? But it bugs me.
It's a nasty one. But there's you're coming from an equity and lens. I mean, the other one is just pure interest. I mean, one of the reasons the UK was so successful in doing their clinical trials is they had a shitload of cases because they had an uncontrolled pandemic. I don't think we want to do that. But that was a real issue when the UQ vaccine was being developed, for example, and how were they actually going to test this thing as Australian researchers? So they set up a international consortium. It didn't go ahead in the end, but that's the other part of it. So you set up an international consortium so that the next time there is a global pandemic, you actually do it globally.
Can I just say, Jodie, too, that bugs me. It's whose interest is it? And I just have a hard time saying, I hate when, people in their ivory towers are making decisions for communities on the ground and deciding what's a priority of research, especially. Adrian Miller and friends have done some work recently that, they looked at pandemic and disaster management plans, and they found that, the plans had no engagement with community at all. That mental well-being was a concern. There was fear related to vaccination and anxiety around mortality rates and families being isolated and weren't able to go on country, and that communication during the pandemic, where lots of misinformation and myths was created apprehension. And, all this research is done by First Nations people and suggested what needs to be looked at and explored further. But then, they're probably silenced and probably don't have access to grants because it's not a priority for policymakers. So I think that needs to change.
Okay. I had a fourth question up here about workforce. We've touched on it a bit, but we have 10 minutes left. So this has been an amazing panel, and I think we've covered a lot of really broad and deep insights. But do any of you have questions for the panel? Yes, Lisette. Yeah.
Thank you. So I guess the topics of cross-disciplinary aspects has been broached upon. So I think something like APPRISE has the capacity to have a top army of public health immunologists and infectious disease physicians. And guess the CDC could take note of that. But I think what's needed, especially for we know that viruses will impact different aspects of our body functions. What I found again with I've got vested interest in the question, but what I found with the COVID pandemic is that the brain is always at and mental health tend to be at the lowest level of priorities. So I think Australia has a lot of experts actually in all those questions. So one possibility is to have an army of reservist army on those particular area. And when a virus actually affect more or less different aspects of the body, that you're able to pull out the different experts that are readily available, because actually the knowledge is there in Australia. The other aspect is that I know you can't talk about everything, but for me, the other aspect that APPRISE would be critical on is the chronicity of pandemics. Pandemics have got an acute phase always, but they have a chronic phase always. And the chronic phase has long-term consequence on the socio-economic structure and budgetary consequence for a country. And I think that chronic aspect really needs to still be taken into account. I think I'm probably talking to a lot of people who are convinced, but I think that's key. There's the last stuff. Sorry, I should have been on the panel. The last stuff is linked to that is the COVID fatigue, that people don't want to hear about this anymore, when actually it's still important. So how do we balance this as potential networks that manage what's being sent to the media? And maybe contrary to what was saying, I think there's a lack of knowledge, a really deep lack of knowledge in the community about infectious disease, and the politicians who are not scientists, they have absolutely no idea what they're talking about. And that would be a critical aspect as well of this kind of networks. And I'm happy if you disagree with me, but maybe not. Anyway, thank you. I just wanted to say that.
Yeah, no, thanks, Lizette. And I think, my immediate response is I'm on WHO Strategic Technical Advisory Group of experts on infection hazards, and Mike Ryan reconfigured that to include expertise in mental health, finance, community engagement, communications, One Health, all of these other discipline areas as absolutely pivotal to infectious disease response, but also obviously these other specialist medical areas, because we don't know the manifestations. But if any other members of the panel had particular reflections or responses on those as well, but I think we acknowledge it's a broader thing than just infectious diseases.
Can I just make a quick comment? Your notion of having standing expertise ready, I think, extends to many aspects of pandemic preparedness. And you can think of it like Ken Griffin from Australian Primary Healthcare Nurses Association, we were chatting about this the other day, so this is credit to him, but so you think about it like a dry sponge, that you have a set of people with capacity, which APPRISE did pre-COVID, who are there ready, engaged with each other, with policymakers who can be mobilised quickly. You've got some obligation, they've got obligations to you, so you can rapidly use them. And that kind of investment puts us in a really good position. It put us in a pretty good position with COVID, and continuing to do that would be important. And I would just say, in terms of the social and economic impacts, that social science needs to be in there as well as standing capacity that's also used.
Could I just briefly carry on from that question? Because the way that the MRFF is set up with various missions, why can't there be cross-mission opportunities? There's a big one around mental health, for example. So we should just keep that in mind.
Yeah. I'm going to keep going because there's a couple more questions and we don't have a huge amount of time, but yeah, sorry, Sharon. He beat you.
Not a bad time to introduce the question of mental health. I mean, a preliminary comment though, I think we all forget that a lot of what was done was really good, and everything we've heard today sort of demonstrates that, every day people presented with a challenge and they kind of rose to the challenge. So there's something about a good, generic, flexible workforce which can't be managed. It's just you've got to have it there. The main point I want to make though was that something I haven't heard about today is the notion of you can only be first the first time. That you've had the first pandemic, and the second pandemic isn't going to be like the first one, not just because it's a different virus, but because the community have lived that story already. And I think this is something that needs to be thought about quite carefully. People are going to remember this until it's not remembered, and their responses are going to be very much driven by their past experience. And I say this especially in the healthcare system, which is just sort of, well, a lot of people are teetering on the edge. A lot of people are hoping that this will be a good year. You know, if it comes again, they won't be able to respond the same way that they did last time. So I guess it's introducing this notion that you can learn from the past, but there's also a future which will be different because of the past, and having some framework for thinking about that impact, which is not all twice. I don't know. I think probably the problems that will happen next time may well relate to the fact that it is the second time rather than the first time. You know, that the staff will just say, this is what happened in the hospitals. And that needs to be planned for.
You're Alex, aren't you? May I make a comment
Yes.
to it? Alex, it just reminds me of the forum we had in Parliament House about long COVID, where every discipline was basically represented, and all types of clinicians, public health people. And I just wonder whether that sort of forum every now and again, by which I mean, you know, once a year or something, would actually be one way of, at low cost, making sure that there is an engaged group that was representative. In this case, it was selected by the Australian Academy of Health and Medical Sciences, but that doesn't have to be the group sponsoring it.
Thank you. I'm mindful of the time as well, and I know Paul has to travel. So if people need to leave, I'm happy to. I mean, I know some other questions, but I'm going to temper that with 2 minutes. Okay. I think Sharon had a question. Or was there any more response? Sorry.
I do just talking about funding in a pandemic, because I do think the main point is it's not business as usual. So Paul, you said we do have some principles around funding, around transparency and all of that, which I totally get. But I think the conversation of then what do we do in a crisis, it needs to be discussed on and agreed. And so then you know to go into crisis mode, because what the UK did was top down, and then they had something like 5 groups: immunology, virology, clinical trials, and they just said, you know, 50 of you go and work it out. You've got to work together. And that sort of as a principle, I think is a really good one for a pandemic where it can be top down and you can move money fast. I do want to just correct the record. I don't like being defensive, but we did have some pre-approved protocols, which was REMAP-CAP, which APPRISE contributed to, Sprint-SARI, which was severe acute respiratory illness, CETRIP-ID, which allowed us to do the initial observational study, half funded by APPRISE, FFX, which was in advanced stages, but actually couldn't get the state governments to agree to it. So actually quite a lot of work had been done. But we hadn't done everything. You know, we didn't have a outpatient-based clinical trial capacity because we never thought we needed one, or a GP fund capacity. And you sometimes can't predict what you need. You know, in Zika, you needed an obstetrician's clinical trial network. So, you know, it's very hard to predict, but I think we had some things in place for a really small amount of money. I mean, APPRISE was, what's that? We spent a lot of time on Sprint-SARI. All right, okay. We spent a lot of time talking about it, but I just want to go back to what I thought the AHPPC didn't like when I came and spoke to them. It was not so much what we did in APPRISE, it was around the ambition of the ask. I was saying to them, the French government have spent, you know, are spending 100 million euros a year on preparedness. The US government's putting in $500 million a year. This all kind of costs money. And then they flipped it and said, well, research didn't really help the UK and the US do so well. But that wasn't the point. You know, it was more about this actually does cost a lot of money. And what the US did well was not pre-approved protocols. They had existing networks in HIV that then they leveraged for their vaccine trials, for their clinical trials. So, you know, so it is investment in existing, whether it's going to be an influenza or ID or whatever it is. So it needs a lot of investment. But I think we should have the conversation about what do we do in wartime, you know, how you switch making decisions. And it needs to be done with NHMRC and MRFF and the Chief Medical Officer. And that we should have that conversation, I think.
Yeah, and it needs to happen in peacetime. That's the key learning. And if it's going to set up another framework for distribution of taxpayers' funds, and it has to be written down, agreed, with all states and territories contributing. Yeah, so that's one of the fundamental things of the CDC. Yeah, look, you know, so just to this famous terrible meeting that's what I talked to, it traumatized Sharon, and I talked to her at length that night, but and it shocked me a bit too, the vehemence. But it was on Alex's what he was saying, you know, it was a very tired group who really, you know, wanted to have more. And so yeah, no, point taken. We haven't got hundreds of millions of dollars. We will never get that for research in this area. But you know, let's all hope for the CDC to have some extra funds to do some stuff. Yeah, I'm certainly hoping.
On that optimistic note, I'd like to thank all of the panel and all of you. And you can send us the figure by a discrete text. We won't share. Thank you so much.